Thanks so much, Greg. We really appreciate the opportunity to do this somewhat atypical cardiology grand rounds on a topic that is not often addressed in these type of settings. In addition to Denise, we're going to be able to welcome up Jill Steiner and also Stephanie Cooper, two people who have been involved in palliative care and also in ethics in our department to present cases during this grand round. Here are our learning objectives. Identify ethical issues in cardiology practice, practice analyzing ethical issues in cardiology, and this is going to be an interactive event. So be prepared to raise your hand, speak loudly so that everyone can hear you. And then finally, we want to be able to discuss ethical and clinical complexities in the case studies that Jill and Stephanie are going to present. And I should note that none of us have any disclosures that are related to this presentation. Well, I want to start by going through a bit of a history lesson. And unfortunately, it's a somewhat unflattering one. Cardiologists in general, at least in the very old medical literature, and you'll note some sevens down here in the references, have difficulty in interacting with terminally ill patients, withhold information from patients at the end of life, have a lower awareness that their patients have a poor prognosis, despite the work of Dr. Levy here, and tend to initiate CPR and ventilation for patients with severe chronic diseases and even marginal prognosis. This has been the history of our field. And yet, cardiovascular medicine is actually a field that has rapid advances in technology. Of course, the randomized controlled trial is our holy grail for all truth. We have had dramatic improvements in longevity and in quality of life, something I think we tend to forget with all of our interventions. As a result, I think we're actually relatively well funded among the medical subspecialties. But the problem is that sometimes our scientific advances tend to outpace the ethical discourse that should go along with that. And in fact, this is a quote, I think, that summarizes a number of ways that a lot of people in our field look at things. This is actually in relation to the work on left ventricular assist devices. And one of the early quotes that defined the field was this idea that, well, there really aren't any ethical dilemmas because patients with end-stage heart failure have wretched lives, and this technology works great. I would say that's not quite true. But it raises the question whether we actually live in different worlds. And I obviously, as chair of the ethics committee and a cardiologist, kind of play in these two worlds all the time. On the one hand, we have ethics, which is decidedly low tech. I mean, we're lucky if we can work a computer well. It's very humanistic, it's very analytical and tends to be philosophical. It emphasizes quality of life, certainly. It's actually really cheap. Ethics really doesn't pay, unlike crime. And we talk about things like the good death. Cardiology, however, of course, is very high-tech. We're very mechanical. We're data-driven. We emphasize interventions and life prolongation. As a result, we cost a lot of money. And death, what is that? Our patients don't die. But I would like to posit to you that this is a false dichotomy, that the traditional way of looking at these things, maybe even what's in the medical literature, is not how we actually live our lives. And that all of us are practicing cardioethics all of the time. And I would say, at least at our institution, we do it well. And actually, this is supported by our national society. So this is actually from a very old ethics and cardiology conference that took place under the aegis of the ACC. And they came up with these things that I don't think have changed over the intervening decades. Cardiologists should provide high quality end-of-life care, preserve the dignity of patients, relieve suffering, and that palliative care should become a priority in resource allocation and education. This, of course, hasn't always happened. Recently, there's more interest in this as part of the ACC. And cardiologists should be involved in advanced care planning. This should not just be delegated to the primary care physician. Now I'm going to turn it over to Denise, who is the chair of the Department of Bioethics and Humanities, to begin to discuss some moral frameworks that are going to give us a very practical way of looking at some of the ethical issues before we actually go into those ethical issues in the cases that Jill and Stephanie are going to present.
Thanks, Jim. Can everybody hear me okay? I'm not too loud. Okay. So how many people here have felt like they've confronted an ethical issue in your practice in the past month? Good. You can interact with us as we talk about this. So listen, so what I want to say is that we have a toolbox as ethicists. We don't just sort of have our own intuition and that's it. We have a toolbox. Among the things in these toolbox are these moral frameworks. So when we get an ethics consultation or one of you says, hey, can you help me think through this? These are the tools that Jim and I are going to be using that I'm going to ask you guys to practice today, and maybe they can be part of your toolbox as well. So one thing we want to do early on, and as you listen to the cases from Jill and Stephanie, try to ascertain, what do you think the ethical question is, you as the treating provider, if you were standing in their shoes? This can be hard to do, and there can be multiple ethics questions, but trying to narrow that down can help you get to the ethical options and the solutions more quickly. So there are more frameworks than what I'm going to go through here, but these are some of the dominant ones that we use a lot in healthcare. So the first thing, just as you clinically are doing a harms benefit analysis to try to figure out what's going to be best for your patient, you're doing the same thing ethically. That will include what benefits and harms you think will ascertain to the patient based on the treatments you want to pursue or not. But it goes beyond that. It can be about people's quality of life, where they may feel, for example, disrespected in some way or another if we are not aligning ourselves with their own goals and values. These are among the harms that we would consider ethically salient. So what you're trying to do in this framework, which we call a utilitarian framework, the best ethical option is the one that maximizes benefits and minimizes harms. So as you think through all the different options, you're trying to think, okay, if I just look through the lens of harms and benefits, which one would I choose as the ethically appropriate action? In addition, you want to look through the lens of duties and rights. So a duties focus we call in ethics deontology. You can just think of duties. And then rights are corollaries to many of the duties, but not all of them. So which duties are in conflict? So you think of your own duties as a physician, you think of duties as a wife to a sick patient or a husband to a sick patient. Do the patients themselves have duties? And how durable or accountable are they for those duties? And is there a practical way to minimize the conflict between these duties? But identifying them can help you because you begin to see where you may be talking across each other because both of you are speaking from a place of your duties, but your duties are actually different. This can include nurses, people in other specialties, etc. And then you want to think about, for a proposed course of action, which rights are we able to uphold? Usually the kind of rights that we don't really dispute anymore, like autonomous, competent patients have the right to make decisions for themselves about their own health care. Are any of those being violated or compromised? Which are being upheld, which are being violated? So you're thinking of duties and rights. The other thing underlying all of this is principles. And principlism is a way of thinking about things through the lens of those principles. There are 4 that we focus on in bioethics. Respect for autonomy, that I think is obvious to everyone. We're usually talking primarily about patient autonomy, but that can expand out. That it can include the autonomy of attending physicians to go the course they think is best. Sometimes that's a factor as well. Beneficence, so it's maximizing benefit, doing what you think is good for the patient. And then non-maleficence, if we understand that some of the interventions you will do in order to help a patient also have harm intended to them, you're trying to minimize them. Okay, so those 2 things are there. And then finally, justice. Justice and respect for autonomy will almost always conflict because justice is concerned primarily, particularly distributive justice, is concerned with an N of many, many more than 1. And respect for autonomy is very individualized. It's about the respect for the person in front of you, right? So these 2 things are hard to balance. We try to look look at the case through the lens of how are we balancing things, these 4 principles, how are they playing out in the case? And then finally, what's familiar to you, even if you don't use the term, virtue ethics. So this is about character. What kind of a physician, nurse, wife, husband, patient, worker do you want to be? You want to be a virtuous one. And all of medical training is built on this model. You apprentice people for a while, you try to model and emulate those that you admire and not emulate those that you don't, until you become somebody who is virtuous. So another way to ask this, which takes into account some of these other things, but it's not direct as the others are, is to ask, what would a wise, virtuous physician do in this circumstance? What would practical reason, somebody who's practically wise, what would they choose? So keep those 4 things in mind, and then we will have quizzes in a moment.
I want to emphasize here that ethics is a rather broad endeavor. I think everybody probably realizes that. A lot of what we talk about in cardiology fall into what I would characterize as 2 sides of the same coin. There's withholding, and then there's withdrawing. And probably all of you are familiar from the ethics courses that you took in your training with this concept that is somewhat settled, I would say, that actually there's really no distinction between these 2 ethically. That to discontinue an ECMO circuit and withholding the ECMO circuit to begin with don't actually have any sort of ethical differences in them, that both of them, under the right and appropriate circumstances, are ethically appropriate. But that's not the way we've all practiced all the time. That's certainly not the way things are viewed by a lot of patients. And so in the interest of time and being able to focus, we're actually not going to discuss the withholding aspect, although that is incredibly important. We're going to focus our attention here mostly on the idea of withdrawal and some of the issues that that raises. And so now I want to bring up Jill Steiner, who is an ACHD fellow, who's been really one of the pioneers in in adult congenital palliative care. And she has a very interesting adult case to present.
Congenital case. Okay. So this is a patient that many people in this room treated and cared for a number of years ago. This was a 63-year-old man with stage D heart failure from an ischemic cardiomyopathy. I'm going to start actually at the beginning of the end of his story when he presented in transfer from another hospital in BT Storm. He had an ICD and had received multiple shocks that morning, never lost consciousness and felt every single one of them. And it's important to notice that he had been discharged home on inotropes for the first time less than 24 hours before this presentation. We'll go all the way back to the beginning of his story, 8 months prior, which is not very long in the interim. He had a cardiac arrest during an anterior STEMI, and this occurred out of the country. He was treated with an LAD stent, had a 2-week ICU stay, and he went home after 3 weeks. Skipping a lot of the details because that's not what we're talking about today. 3 weeks after discharge from that hospitalization, he represented to another hospital in another country with an NSTEMI. He was not able to be revascularized then, although they tried. This was a prolonged hospitalization for him. He had multiple VF arrests. He had what were described as multiple strokes. He was treated for at least 2 UTIs, a Klebsiella pneumonia, and ultimately required trach for respiratory failure. After 8 weeks, he went home. 1 week after discharge from that admission, he represented with an NSTEMI. That time, there was an attempt to revascularize a proximal LAD, which was unsuccessful. And at that point, he was transferred to us for heart failure, advanced heart failure therapy consideration. After a lot of discussion, which everyone's familiar with, he was turned down for a ventricular assist device because of frailty and debilitation. He slowly improved with a slow inotrope compressor wean, but was ultimately unable to tolerate oral goal-directed medical therapy. Eventually, he had a secondary prevention ICD implanted during this hospitalization, and he went home during 5 weeks. Importantly, during this hospitalization, as you might imagine, there were a lot of ethical and bioethical related questions. The patient It became apparent he didn't know what had happened to him over the course of the preceding 8 months. His family told him that he was so sick and weak because of GI problems. And so this took a lot of education and speaking to him, trying to get him to have a clearer understanding of his condition so that he could assist in making decisions with knowledge that was necessary. This was difficult because he was non-English speaking. He had impaired vision, hearing, and speech, all related to his prior strokes and recent illness. But ultimately, he expressed a willingness to undergo ICD implantation, which was kind of where this all came to a point. And the family was strongly in favor of this option as well. And so that happened before he left. 3 weeks after the discharge from that admission, he came back, stayed for 3 days for rule out MI. No intervention was undertaken at that time. And then 4 weeks after that discharge, he came back in cardiogenic shock, and his body couldn't, or his heart couldn't supply the blood to support his bodily functions. He also had a new mural thrombus at this time, had received multiple ICD shocks at home that morning. And after another 3-week hospital stay, went home on home inotropes. And that brings us back to where we met this patient when he was readmitted 1 day later in incessant VT. Despite all of everyone's efforts, he remained critically ill. As you might imagine, there were multiple meetings with his medical and palliative care teams. Through these discussions, it became very clear that being alive and interacting with his family were the most important things to him from a personal, cultural, and religious standpoint. And his family reported a religious obligation to do everything that was possible to keep him alive, prolong his life, regardless of the risk of suffering. Not surprisingly, though, he continued to deteriorate. He lost his own decision-making capacity. His family ultimately agreed to DNR status in the face of what we were calling medical futility, but they were not on board with ICD deactivation. The palliative care team discussed the case with ethics, but no action was undertaken to shut off the ICD at the family's request. Ultimately, he endured 41 ICD shocks in the next few weeks. He was conscious for all of these. These were distressing and uncomfortable for him and his family and his care team. There was a lot of moral distress involved in this case. Ultimately, the family did approve symptom management with medications that could help make him a little bit more comfortable. And he died shortly after. We think his ICD battery became depleted. One of the discussions around that time was whether he'd be eligible for device replacement. I don't want to talk about that so much today, but he did pass away with an asystolic cardiac arrest, and his device did not respond.
Thank you very much. Simple case, obviously. Sure, all of you have got this wrapped up as far as what we should actually do. But Denise and I are going to now turn it to you to answer some very important questions.
Yeah, what do you think are the key ethical issues in this case from your perspective? Yes.
Providing the best care for the patient as you see it and respecting the wishes of the family.
So a tension between beneficence, providing what you think is beneficial and helpful care to the patient, and respecting the authority of the family to make decisions on a decisionally incapacitated patient's behalf. Good. What else? We're all friends here. Yes. Yes. Good. So it's a similar kind of tension, except with a religious tradition that may or may not kind of align, and in this case did not seem to align, although because religious values are so important to people, I think we all recognize that aligning those or violating them in some way can be more hurtful to our patients and their families. Good. Other ethical issues, tensions, worries. Yes.
Highly likely family or understandable reluctance to accept it?
So maybe lack of alignment between the expectations of the family and the clinicians, and then unpacking why that is. And we know that that's multifactorial pretty much every time. Is there anything you want to add there? Any data or anything? Great, thank you. So, yes.
Another issue is, are we doing harm by allowing futilely resuscitate over and over again?
Yes, how many people are worried about that in this room? So this one is really important, and we got to get it on the table early so we can try to suss it out with everybody. Everybody's so worried that this guy's being hurt instead of helped by the intervention that we gave him, right? So if we're responsible for putting that ICD in and managing it, shouldn't we be responsible for stopping it? So this is partly an authority issue. It's about rights and duties. What duty do you have under those circumstances in light of the right of the family to make decisions on behalf of the patient when they're disagreeing with you?
No, absolutely. Absolutely. You can see we've already discussed a number of very complex issues. I think a lot of times in cardiology, I mean, come into a case like this and you have this, what has been referred to as like there's something that's not right about this. But actually unpacking it and figuring out what the issues are that are underlying it and beginning to discuss what our options are and what actually is the right way forward is a vitally important exercise, and that's why we're doing it today.
Yes.
It's really tough when cultural values and harm, like how is that where the families really clinically that we had to continue to keep them alive and care for them until other people could come from the Philippines or wherever to do their traditional. It's tough.
Yeah.
It's really, really tough.
Yes, and what you and the family see as benefit is really different often, right? And harm is often really different. Good. Yes. Good. Yes. Yes. And may have reasonably disagreed about what they thought was best. Good. Can I ask this question as we think about this, sorry, moving on to what options do we have? Would any of you think it would be ethically permissible to turn off that ICD over the objection of the family? Tell me why. Good. Tell me why. Good. So this is helpful. How about somebody who thinks oh, yes, please. Yeah. But I think it's pretty common.
I did my training in a different country up north, and in this situation, that idea of not necessarily asking the family if they wanted to make, but telling them that it is of no use and physicians feeling empowered to do what they felt was in the best. It was sort of a difference in sort of how physicians interact with patients and families when I came down here, where the default down here is do everything and provide everything, versus this idea that physicians might have felt more empowered to do ethically what they want and to not put the burden on the family, because I think a lot of time we're handing the burden to the family when in fact, and frankly, what do they want? say, as opposed to taking that on.
We don't like to think about the cost, but it is very plausible that not only will be spending vast resources that are really could have been spent on others, but that the family might receive it very.
And I think there's also worry about physicians considering that in any overt way. And I think ethically, I think we can. Cost is relevant, and allocation of resources are what relevant. I think what's even more relevant than cost is how we are marshaling the time and the resources within our healthcare system when there are so few of you and so many more people who need you, your expertise, right? Comparatively, a lot more people need your help than can get to you, right?
So let's have a comment from the person who ends up managing a lot of transfers to completely fully got medical. Karen.
Now we have the right answer. It is our responsibility to see so that our knowledge is and we spent a lot of time around there and feel that they made but ultimately most of us feel that the family response, no matter how much this hurts, it will hurt them more if we don't provide the resources. So the somewhat of the patient gets lost in this. He's the one who's suffering from each of the talk because we all know that it's ultimately not disease, but they are going to go on and deal with the consequences of what they for longer than we are. I think that ends up being probably different from the holistic approach that is totally really straightforward. But I don't think American medicine for the years where it's autonomy of the patient and family really allows that to be as acceptable in as it might be in other circumstances.
So that's an excellent comment. So let's get practical here. Denise, I'm on service. This happens to me.
Yeah.
I want to unilaterally deactivate a pacemaker or a defibrillator or something else. What do I do?
So this would be where we would be likely coaching, so figuring out where and when any breakdown in the trust between the two groups occurred to see if we can repair it in some way, number one. And number two, we would be coaching with very specific language, similar to what our colleagues in palliative care do, about how to ask for informed assent. So you're taking the lead and saying, we're turning this off, here are the reasons why, here's when this is gonna happen, so that you take that burden on, and then we'd be looking for all the specific ways you're worried about this blowing up in your face to see if we can figure out a way to help you and make it easier. That would be our approach. Would you agree?
Yeah. UWMC policy for this with a fairly defined set of ways of going forward. If that informed assent doesn't work, then you can go on to the next step. We'll go through all the details here, but it does involve ethics consultation. So if you are in a situation like that, and you are facing this decision about whether or not to unilaterally deactivate a device, in other words, over the wishes of the patient or family, there is a pathway forward in this institution and in many others. We should probably move on. I did want to talk, there's a lot of other issues here, but I do want to just sort of ask this question: what is the device doing? What is it actually accomplishing? And I think we can categorize it in several different ways that might help us and the family members to think about this. One is this idea that the device is merely prolonging death. It may be unnecessarily causing suffering. And if we deactivate it, are we just letting nature take its course? That's sort of the ethical underpinning of a lot of the decisions, and in particular this idea of deactivating against patient and or family wishes. But there are still a lot of controversies about this. If you think about it, defibrillators in particular are inside the body. They're not external things like a ventilator. They're not something that you can point to that is sort of connecting somebody to something. They're actually within. And there's an ethical discourse around this whole issue. And that has led a very smart guy named Dan Somasi to come up with a way of thinking about implantable devices. And he did this mostly for pacemakers because this happened a long time ago. But he talked about regulative versus constitutive therapy, and I think it's helpful to do it. He defined regulative therapy as something that coaxes the body back to its homeostatic equilibrium, something that actually restores sort of a level of function. I may never get to that homeostatic equilibrium, but at least it's moving in that direction. Constitutive therapy, however, actually takes over the function of a body or a body part that can no longer be intrinsically provided. And he further broke this down to some very practical ways to look at what things are doing. Is it acting intermittently, or is it acting all the time? Is it outside the body? Is it inside the body? Is it basically not self, seen as something that's opposite? Now this gets difficult because our work and others have noticed that patients do things like naming their VADs. Sidebar, even Timothy, I don't know where that one came from, but that, or is it really a sense of their own self? We had one quote from a patient saying, well, it's never done me any wrong, why would I turn it off and harm it? Does it respond, does it not respond? So that becomes an issue because obviously most of our devices do some kind of responses, or they will, hopefully in the case of that. Does it actually grow and self-repair like a transplant? Is it dependent on an energy source? Of course, that gets interesting when the energy source is internal. Is it dependent on external control? Well, you can put the programmer on there and actually tell it what to do. Is that external control? Is it immunologically compatible? Well, transplant tends to not be, whereas the device often is. And is it physically distinct or integrated within them? And I think it's helpful for us to view this because this is how patients and families are viewed. And actually, it's how we view it too. We did a nationwide survey of HRS members, Heart Rhythm Society members. We asked them, how would you characterize ICDs and then pacemakers? And we sort of gave them some options. Is it like a coronary stent, it becomes part of the body? Is it like external defibrillation, applied therapy? Is it like dialysis, that it kind of is keeping things going? Or is it not like anything else? And interestingly, most of them said, or the plurality said, it's not like anything else. It's a unique category. Whereas with pacemakers and a pacemaker-dependent patient, they thought this was much more like sort of constituent, let's keep things going, like dialysis. Now, the Heart Rhythm Society is a very thoughtful organization. I served on the ethics board until recently. We talked about a lot of conflict of interest, but they also did some other issues. And they actually, in 2010, came up with this expert consensus statement that was really, I think, very interesting and highly influenced by the ethicist on the panel. So ethically and legally, there's no difference between refusing CIED, or basically pacemakers and defibrillator therapy, and withdrawal. What we said earlier, withholding and withdrawing, same thing. Ethically, deactivation is not physician-assisted suicide, or we would call it physician-aided dying in Washington State, nor is it euthanasia. And there's no treatment, including these devices, that have unique ethical or legal status, even if they're implanted inside the patient. But even though this is very clear from the HRS statement, we all know, according to the great philosopher Yogi Berra, in theory, there's no difference between theory and practice. In practice, there is. And with that, I'm actually going to switch gears a bit and invite Stephanie to come up and discuss her case.
Okay, this is a really different case, actually. And I took care of him for a long time, so I'm going to have to leave out a lot of detail and nuance due to time constraints, which will come up later if necessary. But anyway, he came to me with a meth cardiomyopathy. He was on no meds. He had an EF of 15%. He basically had no past medical history at the time other than obesity, ongoing tobacco use, meth use. But my initial visit with him, he was really restless, talked a million miles a minute. It was very hard to focus. And with questioning, it came out that he had been told at some point when he was a kid he probably had ADHD. He also barely graduated high school. He was essentially illiterate. He could read a few words, but couldn't read fluently. And he also copped to a pretty severe anxiety disorder. None of this had ever been really diagnosed or treated. He expressed at that first visit that he wanted to quit meth, that he wanted to get his heart better, then he wanted to follow recommended therapy, etc. So he was established in our clinic and was actually deeply established in our clinic. He saw my nurses there weekly, and there were periods of time over the years that we took care of him where he called the clinic daily. He sometimes would come in confused, a little distracted about his medications, but he was clearly trying to manage his medications. Many sets, he had little compartments, and he would sometimes get overwhelmed and stop his meds, or, like I said, get confused and not take them right. He would be abstinent for months at a time, but probably no longer than months at a time. And sometimes he'd come to clinic, and actually we all became fairly inured to his personality issues, which included that he was often irritable, sometimes would come already angry, sometimes would call the clinic angry. And a lot of these calls over the phone would involve him telling us what he'd been eating, which would be like an entire pizza or an entire slab of bacon at a time. And in the first few years, he was hospitalized for congestion, not that often, but a few times. And these hospitalizations were very difficult for him. He was claustrophobic, he was overstimulated, he didn't like his roommates, he didn't like being in our OBS unit, in which there's essentially no privacy and it's loud. During one of these admissions, we consulted psych because he's a pretty big man, and when he was agitated, he would get red in the face, so he'd actually scare the nurses because he'd be so agitated. He'd never threatened or did anything violent. But the psych consult was basically to leave him alone and give him some space when he was agitated or angry. He had to leave the floor a lot. That frustrated the cardiologist taking care of him, and there was, people thought he probably was going to the cafeteria and eating and drinking whatever he wanted. We were trying to decongest him. And although he had periods of getting better and worse over those years, he essentially remained in very symptomatic heart failure. He also did have a number of comorbidities, which were diagnosed pretty early. The first was sleep apnea, which he declined therapy initially. Eventually, though, he needed BiPAP, and he took ward all night. He ward a lot during the day as well. He had at least moderately obstructive COPD. He did not have diabetes when I met him, but he did develop diabetes over the years, and it became incredibly out of control. I mean, he'd come into clinic with blood sugars in the 300s to 500s. Meanwhile, I was shopping him around to psych clinics, trying to get help for what I really thought was the driver of my inability to control his heart failure and his inability to take care of his heart failure. He probably had anxiety. He was given a diagnosis of mood dysregulation disorder, maybe bipolar type 2, blah, blah, blah. Most of the psychiatrists he went to see would be like, okay, see you again in 3 months, which was not the level of support that we were looking for. Finally, in the last year I took care of him, he was pretty close to recovery. After a few years, he was admitted multiple times, and the admissions were no easier for him. And not only that, they began to become not clearly of any utility. So he would come in, he would get frustrated and leave AMA. So if we titrated up on his medicines, he wouldn't leave with them. So we'd have to start all over again anyway. Even though he was not diuretic resistant, and we were ostensibly diuresing him because he was peeing a lot, he wouldn't lose any weight. So he and I had a discussion, and we talked about that the admissions were distressing for him and that we tried to take care of him primarily in clinic. We weren't talking about hospice care, we were just talking about trying to prevent the distress of his admissions. So we'd give him IV diuretics in clinic, and like I say, he was calling our clinic daily and we were seeing him literally weekly. He underwent a lot of procedures. So we got an ICD, which you could argue the utility in somebody who's using meth, but he did VF twice and was shocked out of it twice, both in that setting of meth. He later in his course was ATP'd and shocked for VT in the setting of hypokalemia from taking too much pentolazone. I put a CardioMEMS in him, which was of no utility because the problem decongesting him wasn't that I didn't know that he was volume overloaded, but his behavior. And his EF had initially improved from 15 to 30s, trying to back down to 20s. His heart dilated, he got MR, so I sent him for a MitraClip, hoping that that would help compensate him. Finally, near the end of his course, he was admitted pretty much monthly, and these admissions were long. A couple of these were at the UW, and when he was first admitted to the UW, we basically reiterated everything we had gone through 6 years earlier at Harborview, which is he was told he wasn't allowed to leave the floor, he was agitated, the nurses didn't like taking care of him, the physicians didn't like taking care of him. In their defense, he took off his tele and left the floor and came back and was found down twice. During one of those, he was intubated, and during that period of intubation, he actually was decongested, just further reinforcing that we thought that the inability to decongest him in the hospital was primarily due to his behavior. In fact, multiple of these admissions in the last year, we'd get him peeing 10 liters a day, and he still wouldn't lose weight. So he and I ended up talking about how not only were the admissions distressing for him, but they actually, even the admissions turned out to be of little utility. And I began to recommend hospice care to him. We got him through we got him through long enough for him to go on a camping trip with his family, which is something that he and his family were really hoping for. And then he came back and was admitted for comfort care and died. So this was a really difficult patient to take care of because throughout the entire course of taking care of him, he had multiple admissions. He was a burden on our clinic. Nobody ever complained about it, but he was a burden on our clinic. We didn't really compensate any of his comorbidities. Everything was out of control primarily because of his inability to control his behavior. It was difficult to take care of. Physicians and nurses didn't like taking care of him. We got a lot of procedures, probably none of which were of significant utility. And in my view, his mental health issues were actually never fully addressed or treated.
It was really excellently presented. So with that, let's move on to the ethical analysis of this case too, and we won't have a whole lot of time left here, but we'll move quick.
Yes, what are some of the ethical issues in this case? Standing where Stephanie was standing. Yes.
So his behavior and his want to be better, and his inability to be as a partner. So
Okay.
The opposite of duties. Yeah. And I think that he's always super
And whereas we have really professionally reinforced duties, the patient may have a duty and really have no obligation to follow through, right? Especially if we've imposed the duty on them in some way or another. So, and the thing that you're talking about, I think happens a lot and causes a ton of moral distress, where a patient says, I want this, and then their behavior suggests the opposite. And at some point, we sometimes, and I know others in the room, will go, we have to decide whether we're going to listen to what you say or what you do. And we have to listen to your behavior under those circumstances, because what you say is too contradictory. Great.
Mm-hmm. And I think we all have to recognize too that all of us to some extent have trouble doing the right thing to maintain our health. And sometimes it's just a little bit more magnified in some patients, particularly if they do have these mental health disorders. And we have to have a little bit of grace and understanding.
Which just makes your moral distress greater and greater and greater as you're trying to care for someone.
Hi, Lou. And I just want to highlight what I thought was a brilliant move by Stephanie, is to say, let's do this as an outpatient, even though it's not what we would normally do, because we're making trying to work with the patient.
And can I just say really quickly, that's a fundamental justice issue. And what happens is because others aren't addressing it, who are not in healthcare, like, you know, the government, et cetera, then it falls to you guys adding to the stress of caring for those folks.
Oh, maybe.
So, I don't know about somebody who's actively using that study. Do we as physicians have an obligation to offer that and to replace it when they don't stop using the medication that's causing them? And I'm not sure where that stands, but
It's not in the proportional response.
it is not.
Not yet. I really,
Comes very often. They promise never to do that. And they overdose and years and device actually saves their life. I don't know what's the excuse behind
So can I just say one thing? I think you guys make a really good point. And one of the ways I test myself on this is to ask, and I have to ask you because I'm not a cardiologist, would you place a defibrillator in a different patient who has a different sort of behavior, let's say diet or something else, that would cause them, right, it's that behavior that got them to have the ICD and they're not changing that behavior because that's the same thing as the medication. That's my test of myself. And the question is, do we, and how do we distinguish between those two? Yeah. Yeah.
We may do it without law. Methamphetamine is not legal. And so the question is there something different? And the secondary prevention is a lot more random. Patients who years ago they refused to put a defibrillator in because you had cardiac arrest after having cocaine, and he went out and had an arrest again. And I was a little frustrated with that because they already survived the cardiac arrest and was declined the defibrillator by our ED colleagues. And here, this primary prevention is put in. I don't know.
Yeah.
And if somebody's not as non-adherent, it's one thing, but when you have a non-adherent patient who doesn't take his medicines, who anti-urease and other things, I don't know about the defibrillator. It sounds like it wasn't too hard to talk into it.
I wonder, since a lot of the issue of diet, I think it is quite different compared to active using that. If you have survived the cardiac arrest in the past, you feel that, and now you're using it again, I think it's almost suicidal. In my opinion, it's not a non-compliance, it's not a question of non-compliance, but actively bringing it on in an acute situation. As compared to like long-term non-compliance with diet or medication, it takes a long time to kill you.
so this is a great discussion and we are running out of time, unfortunately. I'm going to skip through this next slide, but I do want to address this issue. We throw around the F word, meaning futility, quite a bit. And the reason that I make that connection there is that it is ill-defined when we use the term. This is just one formulation of trying to drill down what we mean by futility. We can think of it in terms of physiologic futility. Trying to defibrillate PE arrest doesn't work, makes no sense. But really what we're talking about most of the time is either quantitative futility, which means there's a very little chance of working, and you can define this however you actually want, or there's a qualitative futility issue. It won't actually produce an adequate quality of life. So we don't put ICDs in patients with end-stage Alzheimer's for the most part. But we have to be careful when we use these terminology, especially with patients. I don't know how many of you have had this situation in which you come and say, oh, this is not going to work, it's futile or whatever. The patient goes on the internet, comes back and says, well, look, this worked in this one case. And then we look a little bit bad because we've been so dramatic about our presentation in terms of utility. We have to be more precise in our language. And whatever formulation you use, I would strongly encourage you to think through what that means and to communicate your thinking behind that. And if you want to use these categories, I think that's great because it opens up the discussion. And I think most patients and families can begin to engage on what the sort of device or intervention or therapy is actually doing and whether it's going to be any good based on these different parameters.
As Jim sort of suggested, strict rule to me is never use the term futility with families or patients ever. That's something we talk about behind the scenes to help us understand and to work through it. But the notion of futility, this idea that it's not worth it will be heard as it's not worth my time to help this loved one, and that's of course never what we do.
Yeah, absolutely. And actually, there's a National Society of suggestion we really should use the term medically inappropriate instead. Well, we hope that we actually stimulated some thought here, and I think by the number of hands that we didn't get to, we've been somewhat successful. Go on and continue to think about these issues and continue to wrestle with them. No, also, I would be remiss if I didn't mention that ethics consultation is available 24/7 throughout the year, and we're always happy to participate in thinking through these different difficult issues. And just finally, in way of thanks, I want to thank all of you for being those people in the trenches, for actually dealing with these tough issues and wrestling with them. You have joined a noble profession, but it is not an easy profession. And all of you, as far as I can tell in my short time here, have done a phenomenal job, and we thank you for that.